Hi, I'm Jenifer Lightdale, an Associate Editor on Gastrointestinal Endoscopy, and it is a great pleasure to be here and interview Dr. Todd Baron, who is essentially my boss for Gastrointestinal Endoscopy as head of the editorial board. And Todd has authored a review entitled A Comprehensive Approach to the Management of Acute Endoscopic Perforations.
Yes.
Hi, Todd.
Hi.
So, tell us a little bit about luminal perforation.
Okay. All right.
And
Yeah.
you lay it out there
Okay.
as something we all dread.
Yeah, exactly. Well, just to give you a backdrop, because I do a lot of advanced endoscopic procedures, of course, this comes up. And I think the more you try to do aggressively endoscopically, the more you might lead yourself into these sort of situations. So there's always been a disagreement amongst even specialists, and I happened to be on a flight back just before I got on a flight from Europe. Somebody said, "Oh, your patient, when you were gone, had a perforation and they went to surgery." And I said, "Well, I kind of disagree that they actually needed that management." And it somewhat got me mildly enraged, and so I took out my anger by sitting down and writing. And I said, because it comes up a lot, that these sort of things come up, and there's so much confusion. And I literally spent the entire flight typing this out, but took me 3 years to do that. It started in 2009 and kept revising and revising it. And so, but I think it's important because it does come up a lot, and there's so much different opinions about how to manage it. And I've seen patients that clearly didn't need surgery, that I think went to surgery, and I've had people that we stayed away from surgery and they did well, even though people thought, no, this isn't really going to work. But on the other hand, you don't want to delay surgery in somebody and then have a worse outcome because you're either proud or you don't want your complication to get away with you. But so there are a lot of things that drove me to write this particular paper.
Well, it's pretty awesome.
Thank you.
And obviously you actually took a fairly dogmatic approach. So, it was pretty terrific. You lay it out as 10 commandments for every endoscopist.
Right.
Can you take us through the top 3 or 4 10 commandments of what we should do with luminal perforation?
Well, I think the first one is that free air in and of itself doesn't mean a patient requires surgery. And I think this applies even to people that are not gastroenterologists, that are residents in training, because a lot of the patients are managed by residents that are on the service, but they may get a knee-jerk response or have been told if you see free air, that means they need an operation. So that was the first thing, is to let people know that if you see free air by itself, rather than just reflexively, don't panic, exactly.
Right, and don't call the surgeon
immediately.
Exactly,
right. That was number one. I think the second most important thing is that prompt recognition really is a major determinant of outcome of endoscopic perforation, because the sooner it's recognized, especially intraprocedurally, then you can have your opportunity to intervene right there, close the problem, fix the problem. Or if you can't fix it, at least you've identified it so that somebody else can intervene early, because it's really the delay in not recognizing and then having egress of contents out of the lumen into a space that's normally sterile, but then becomes infected, and that's what causes the morbidity.
And I believe you also talked about, one of them, I believe, is that intestinal air itself does not mean it's infectious, right? It's or not infected yet.
Right,
by
exactly.
definition.
And that's why if people see air, they shouldn't panic, because if it's only air, that's not going to hurt the patient unless it's air under tension, which is then manifested by tension pneumothorax, tension pneumoperitoneum, that requires management. Those things are clinically fairly obvious, those last parts.
Okay, and of course your paper lays out so many great things. So it must have been a terrific flight home.
And 3 years, yeah.
But actually, in particular, the early versus late signs of perforation.
Right.
So can you review those briefly for us?
So the early signs would be that the patient generally will have pain, maybe out of proportion to what you'd expect, or abdominal distension. The later is really the infectious complication. So if it's not recognized, the patient goes home, or it's delayed, they develop fever, leukocytosis, tachycardia, and those are the things that are really red flags for something going on that's bad after perforation.
Which brings us back to commandment number 2, right? Prompt recognition is important.
Absolutely.
So how did contrast help you decide how you're going to pursue intervention?
So I think contrast is very helpful, because it tells you whether or not you still have an ongoing leak. and how big it is. So if you, for example, intervened, you felt like you closed the problem, then you get a contrast study that either confirms that the leak is closed, then you can feel pretty good about the fact that there's not going to be additional leakage or spillage of contents. And if it hasn't, then you really know you still have more work to do, and it either needs to be managed a different way or managed surgically.
Okay. All right. And then I really learned so much about different types of perforations too, and like different locations. So, were there certain facts that really stood out to you as you were reviewing all of these different types of perforations?
Yeah,
what did you learn in the process?
I learned in how many perforations I've actually had.
Oh,
that's what I learned.
Really?
No, because every one of those images in there, except for one, is actually one of my cases.
That's
so,
awesome.
Yeah. Well, but I've had a again,
you've had experience with every type.
All these, yeah. But I think the one thing that people should know is, for example, gastric perforations to me are completely different because, as you know, the stomach is so forgiving, especially if it's not in the fundus or the cardia, then those tend to close just like when you pull a peg tube out. So if you prevent egress, I've seen large perforations in the stomach close just simple NG suction fairly quickly. And I think people should recognize that. And probably the most dangerous of all, I think, are the colonics, which probably most people know because you can't divert those patients. Because one of the principles in this is diversion. You can divert NG suction and divert contents that way, but you can't really do that in the colon. So it's really either closure endoscopically immediately or surgery. So I think those are the important things.
Well, thanks for writing it. It was
Thank
definitely timely.
Thank you very much.
No.
Thank you.
All right.
Thanks.
Thank you.